Good afternoon, everyone. It is Friday at noon, which means it's time for our TDH novel coronavirus update for clinicians. So I'm Dr. Michelle Fiscus. I'm the medical director of the Tennessee Vaccine Preventable Diseases and Immunization Program, and I am safely spaced approximately 2.6 miles from Dr. Elizabeth Rice, who will be joining us today from Vanderbilt. She's an assistant professor of medicine and the medical director of the observation unit there at Vanderbilt. So she's going to be talking in just a couple of minutes about what their experience has been at Vanderbilt with adult inpatients who have been hospitalized due to the coronavirus. But first, we're going to give you some updates on the statistics around the state. So we are 135 days into our incident command system here at Tennessee Department of Health, and it's been 85 very long days since our first case. We still have our clinician call line that is stood up from 8 to 4:30 Monday through Friday, and then on weekends and after those hours, we always have one of our physicians here in the Communicable and Environmental Diseases Program who's on call for public health emergencies like rabies and tetanus and carbon monoxide exposures and other kinds of things that can't wait until the state opens back up. This is a look at the global picture. 5.8 million cases confirmed across the globe as of late last night, and about 15 million test results that had come back in the United States. You may have heard on the news that Brazil is having a particularly bad time right now with increasing cases of coronavirus. On the right side of the screen there, you'll see the daily case counts across the world, which you can see still continue to move upward in their trajectory. So we had what may have been looking like a plateau for a little bit there, but that's started to peak up a little bit. Here in the United States, as of last night, we're at 1.7 million cases, about 95,000 deaths, and there's varying numbers depending on who you look at for your data on that. Some say that we've crossed the 100,000 death mark. Other places don't quite have us there yet. And we've got about almost 29 deaths per capita in the United States. This is the graph of the 7-day average in the United States. So that's the blue line that you're seeing that has come down really nicely. World Health Organization really wants us to be below 5%. You can see that the testing numbers have been increasing, but the positivity numbers have been staying relatively low. There might be a little swoop up here in the last couple of days in that positivity number, but generally staying right at around that 5% mark where we should be. When you look at testing across the country, Tennessee currently ranks 13th in the United States by population for its testing. So you can see our green bar there, that's the number of tests. The yellow bar at the end is the number of positives, and then there's a dark blue bar at the very end, which is the number of deaths. So we're high in our numbers of tests. For a state our size, not doing too badly with the case numbers and with mortality at this point. This is where maybe we should start getting a little concerned, though. So this is the 7-day positive average for Tennessee, and we had come down fairly quickly. You know, right at the beginning, we were really only testing people who we suspected were positive, and so that positivity percentage was really high in the beginning of this back in early March. Came down pretty quickly as testing numbers started to go up, and then we had a couple of peaks. These are the dark yellow numbers at the bottom, dark yellow bars. Those are the positive cases. So you can see the peak where we had a large number of positives in one of the prisons. But here over the last 7-8 days or so, we've started to have this steady rise in the 7-day positive average. And this isn't even really accounting yet for the reopening that happened over the course of the last week and the gatherings over Memorial Day weekend. So it's a little concerning to see that fairly steady rise in positive rate. And we are bumping right up against that 5% threshold that we really want to stay below. So I expect over the next week or so we may see a continued increase in cases as people start to get out and about, and especially with having just passed the Memorial Day weekend. As of yesterday at 2 o'clock, we were at 21,679 cases in the state. That was up 373 since the day before. And we've generally been running about 300 to 400 new cases that have been identified a day. 14,632 that are considered recovered, and so that recovered number was 716 yesterday, which was nice. That's almost twofold of the new case numbers that had been identified. Deaths were up by 3 to 356. Hospitalizations took a good jump of 42 over the previous 24 hours, and we're running generally about 6,000 tests a day through the week at 415,989 as of yesterday at 2 o'clock. And we update these numbers every day at 2 p.m., 7 days a week, at tn.gov/health if you want to see those numbers, and then you can see the breakdowns by counties and demographics at that site as well. Here's what our epi curve looks like, and it doesn't look like a typical epi curve because this is diagnosed by testing, and those tests are run mostly Monday through Friday with fewer numbers on Saturdays and Sundays, so you have this constant up and down kind of rhythm to this. You can see the red line there that we've continued to track up, maybe with a little bit of a plateauing here recently, but in the gray box there, all the numbers aren't complete. Of some concern now is the number of people hospitalized for COVID-19. So we saw that big uptick yesterday in the numbers, so 279 total inpatients, and we're nearing the highest point that we've been since about May the 18th. And then that also had a corresponding uptick in ICU patients and also in ventilated patients. So that's going to be something to watch really carefully over the next couple of weeks as we start to see more cases come in as a result of people getting around more. We've tested at this point about 6% of the population in Tennessee. The death rate is 1.6%, which is a tenth of a point decrease from what we've seen since the beginning of April. And we continue to see the vast majority of those deaths in the 61 to an older population, of 85% of the deaths being represented by those classes. We've seen a good jump in the number of cases that have been identified in children and adolescents and young adults over the last week, up to close to 2,500 cases now, coming out to about 11% of the cases that we're seeing in the state. So I'm going to end the usual update a little bit early this week because we were really fortunate to have Dr. Elizabeth Rice from Vanderbilt on with us today to talk about what's going on in the hospitals with acute care and hospitalization specifically of adults. And she has a lot of information that she wants to be able to share with you today, and I want to make sure we have plenty of time to hear from her and also still get your questions at the end. So I'm going to turn this over to Dr. Rice, and it's really great to have you on with us today, and I will run your slides, so thanks for being with us.
Thank you for having me. I'm excited to be here. These slides will discuss a fair amount of the experience that we're having at Vanderbilt in the care of our COVID-19 patients. So this first slide just depicts how this illness has two stages. Patients who are in the early phase, or what we call the viral phase, may be asymptomatic or have dry cough, mild shortness of breath. But in this phase, patients are basically experiencing symptoms due to the virus itself. As the illness progresses in time, some patients will have a host response, immune response, that's robust enough that that actually is taking over what causes their symptoms. And the patients at this point may develop more severe symptoms, including acute respiratory distress, organ failure, and even death. This depicts well a lot of our patients are on the floor in the hospital. So they may be on a low level of oxygen supplementation for a couple of days and go home, or they may stay with us and then around day 8, 9, or 10, sort of start to decline and have a higher oxygen requirement. So it fits well for that group. I will say there is another phenotype, though, where patients present with a rather rapid progression to organ failure, acute respiratory distress syndrome, and so forth. We can go to the next slide. So this slide is the most common symptoms that people are very well aware of: cough, shortness of breath, and in some patients, diarrhea, nausea, vomiting. You've probably, let me just say one thing about that slide. You've probably heard about this, but there are patients who their symptoms far out do not accurately reflect their acuity of illness. So they may say, I'm feeling fine, and they're requiring 6, 8, or even 10 liters of oxygen supplementation. That silent hypoxia is what you may have heard labeled happy hypoxemia. This slide depicts what China, the early part of the pandemic, experienced with cardiac complications. So in a couple different case studies involved around 150 to 200 patients, you see 23% developed heart failure. From 7 to 17% had what they call acute cardiac injury. This is what we would think of as a myocardial infarction. And they described about 17% of patients having an arrhythmia. I'll be honest, we have not seen these cardiac complications at Vanderbilt, though we have seen the mild increases in troponin that Lippy and colleagues described in their publication. There are renal complications in many of these patients. So Chang and colleagues reviewed a case series of 710 patients, and approximately 16% had acute kidney injury at presentation. An additional 3% developed AKI during their study period. And then Cummings and colleagues looking at over 1,100 patients in New York City saw 6% of admissions requiring renal replacement therapy, and that amounted to about 20 to 40% of their critically ill required it. At Vanderbilt, what they see in the ICU when patients develop this is a very sudden onset of anuria with a doubling or higher increase in the creatinine. When the kidneys do recover, that typically follows pulmonary recovery and is just as sudden in its improvement as it was in its worsening. We can go to the next slide. There are neurologic complications associated with COVID-19 as well. In this study by Mao and colleagues, again from the China experience, they had approximately 4% of patients had strokes, about 3.7% had an impaired consciousness, which could refer to either somnolence or the content being altered, meaning something like a delirium. Less than 1% had seizure. We do see some patients present with an impairment in smell or in taste. Interestingly, one of my colleagues at the hospital who was diagnosed only experienced a loss of smell, and that was their only symptom. So these complications are being seen in multiple patients. Next slide. In the literature, there's several skin manifestations that are being discussed. COVID toes do seem to be unique to the COVID illness. Formally, they're described as a pernio-like lesion, and it's this erythema on the dorsal surface of the toes that seems to be related to an inflammatory condition. It's seen in more mild illness and resolves as the COVID symptoms resolve. This, on the other hand, so these are two pictures of the same patient who developed livedo-like lesions, or more formally known as livedo rasmosa. This is seen in older patients more often and is associated with more severe disease. And probably the concerning part about this lesion is that on biopsy, there was evidence of intravascular thrombi. And these two variations of skin manifestations, a viral exanthem, morbilliform rash that we see with lots of viruses, particularly in the children, even more so than adults. This was the most common dermatologic finding in a Spanish study of approximately 375 rashes that presented in COVID patients. We also see an urticarial rash, nowhere near as common. About 19% of patients had that. I alluded earlier to livedo-like rash being concerning for this intravascular thrombotic picture on biopsy. And certainly that raises more concern about is there a hypercoagulable state associated with COVID-19? So there's no doubt about it. There are laboratory abnormalities of some of the various parts of the coagulation cascade. We see an elevated D-dimer, an elevated fibrinogen. We see some alteration in coagulation studies and in mild thrombocytopenia. And in some patients, there have been reports of lupus anticoagulants. But it's unclear if these hematologic or changes, these lab changes, actually refer or manifest as a hypercoagulable state. We have some concerning data. So this study of 150 patients in the intensive care unit on venous thromboembolism prophylaxis, still 17% developed venous thromboembolism, and that was a French study. Just yesterday in Critical Care Medicine Journal, Indiana gave or published similar data. They followed approximately 110 patients on venous thromboembolism prophylaxis. These were all critically ill patients, and again, they saw an even higher rate of 25% venous thromboembolism. On the other hand, we have some reassuring data from New York City, 393 patients. Again, most of them who were critically ill, only 3% developed venous thromboembolism. So with this conflicting data, what do we do about thrombosis and the risk of it in our patients? So the next slide. So at Vanderbilt, and we are following what the American Society of Hematology and National Institutes of Health have put out as guidelines at this point in time. In hospital, we provide venous thromboembolism prophylaxis for all patients, regardless of their risk score. And the recommendation is to use either enoxaparin or heparin, but ideally enoxaparin based solely on the fact that there are fewer times it needs to be administered during the day and therefore reduces the exposure risk as well as the use of PPE. You may hear out there some facilities have developed protocols using intermediate levels of anticoagulation or even therapeutic anticoagulation as their means of prophylaxis. That is not recommended at this time by either society. For those patients who do require therapeutic anticoagulation for something like atrial fibrillation or a history of blood clots, the societies recommend using in the hospital either enoxaparin or heparin, rather than the patient's home medication of warfarin or apixaban or something like that. And the reason that they recommend this is because several of the therapies that are being investigated for COVID-19, those drugs interact with warfarin, with apixaban, with betrixaban, and all those sorts of drugs. And so to minimize that drug-drug interaction, they recommend converting to enoxaparin or heparin in the hospital. We know that even patients who don't have COVID-19 are at some risk of having blood clots develop after discharge. And so in this risk of uncertainty with COVID-19 and that baseline risk, what do we do with patients after they leave the hospital? Currently, routine prophylaxis of all COVID-19 patients is not recommended at discharge. You may recall the FDA approved rivaroxaban and betrixaban to be used in high-risk prophylaxis. And the studies that were included to receive that approval, the study involved a scoring system where patients' age, comorbidities, and D-dimer were combined to determine their risk factors. So you could use such a risk factor system to determine patients that might need prophylaxis at discharge, but not routine prophylaxis in all patients at this time. Ash goes on to just say that those patients who do have low-risk orthopedic surgery, prior studies have shown that aspirin is useful in these patients, and they say that can be used in this situation as well. Are patients co-infected with other illnesses? There seems to be a high incidence of respiratory virus co-infection. Some studies suggest as high as 50–60% of patients with co-infection of other respiratory viruses. But bacterial infection seems to be less common. This is a little hard to tease out because often people are being empirically treated because concern for the overall illness and they're declining and they're being empirically treated with antibiotics without blood cultures or sputum cultures and so forth. But studies suggest that it's a 2 maybe as high as 8% bacterial co-infection. These patients are clearly at risk of the same hospital-associated infections that any other patient would be at risk for. And interestingly, the critically ill may be at increased risk for aspergillosis. Kohler and colleagues from Germany reviewed 19 ICU patients who did have, 5 of whom, had pulmonary aspergillosis. And so this is an area that's of interest and more concern, and we'll certainly hear more about it later, I presume. So how are we treating our patients? The happy hypoxic patient, which is the floor type patient, cornerstone of therapy is supportive care. So they're receiving oxygen and other respiratory interventions that limit aerosolization. We do use high flow oxygen in those patients who require it. There was some question about its use early on. And we do actually use non-invasive ventilation when indicated as well. There's a modification to BiPAP that creates a closed circuit, and so we are using non-invasive ventilation at times. We use metered dose inhalers rather than nebulizers, again, because of the aerosolization risk associated with nebulizers. We treat their underlying diseases, and as we mentioned, we use the prophylactic anticoagulation regardless of their VTE risk. And then we have a daily huddle that we call the COVID Huddle, and you can go to the next slide. COVID Huddle is a multidisciplinary meeting with our primary team, the hospitalists, infectious disease, pulmonary, hematology, oncology, and palliative care all present. In addition, we have representatives from some of the trials that are ongoing at Vanderbilt, and then the COVID to Home program is also there, and I'll talk more about the COVID to Home program in a few slides. But this multidisciplinary group talks about each patient, patients who are doing well, it may be just 2 or 3 lines saying they're doing well. Those patients who may be around day 8 or 9 and seem to be getting worse, we have the opportunity to talk with our pulmonary colleagues who may review their chest x-rays, and infectious disease colleagues who think about co-infection with us and things like that. And then certainly it's advantageous to have trial representatives there who can help us consider whether or not these patients should be placed on a trial if they've not already been done, if that hasn't already happened. This slide just depicts what are we doing in the ICU to care for our patients. This is evidence-based medicine that's been studied and published over the last 20 to 30 years in critical care medicine. On the left side of the slide, you'll see patients who are on high flow nasal cannula or non-invasive ventilation. If they worsen and intubation is needed for a SAT less than 88%, then we are intubating and instituting low tidal volume ventilation. We do use high PEEP, as studies indicate should be the supportive method. In some patients, we are proning them, steroids when indicated. We do use conservative fluid management as we have before. And if fluids are given, we do use balanced crystalloids rather than saline. And last but not least, we have daily spontaneous awakening breathing trials in hopes of being able to extubate some of these patients. Despite this supportive care, some patients develop COVID spells. And so what are these COVID spells? It refers to sudden worsening of their oxygenation. They have abrupt onset of hypoxia. And in floor patients, this worsening hypoxia luckily responds to increasing the oxygen level. However, in ICU patients, I want to hit again, this one I had some animation in that is still there, I guess. With ICU patients, the hypoxia is often refractory to manipulations of the ventilator, including increasing their FiO2 or increasing their PEEP. In the ICU, it's often accompanied by hypotension as well. And these spells may last a few minutes to sometimes in the floor patients, it lasts hours. So we may have a patient who's on 3 or 4 liters, and suddenly the next day in Huddle, we're talking about how overnight they became hypoxic and were turned up to as high as 10 liters. And we're in the process of weaning them back down again. So these COVID spells are occurring in our patients, both on the floor and in the ICU. They're distressing, and we aren't sure exactly why they happened yet, but on the next slide, you'll see a recently published study by Lang and colleagues in the Lancet journal that may explain this. So on the left of this slide, you see a traditional CT scan that we're all used to seeing, and you can see the peripheral infiltrates from COVID illness. On the right-hand side, these pictures are generated by a dual energy CT scan, and the right-hand side is actually a perfusion study. And where you see the yellow and orange areas, that's less perfusion. And in the area where you see red or maroon, that's a higher perfusion. You may remember back to your physiology classes years ago, at least for me, it was years ago. The lung is the only organ that typically, in response to hypoxia, vasoconstricts. That seems logical, right? We're trying to move the blood to an area that will actually perform the oxygen exchange that we want it to perform. However, in these COVID-19 patients, this study, and they had several patients in this study, I can't remember the exact number, I apologize off the top of my head, but they had these pictures where instead of vasoconstricting and shunting blood away from the affected area, they actually are seeing vasodilatation and shunting towards the affected area where oxygenation is not happening as well. And so this may explain some of these refractory episodes of hypoxemia, though there's clearly more research to be done. Go to the next slide. So let's take a few minutes and talk about treatment with medications, not just supportive care. So many of you may have heard, just last week it was finally published, the remdesivir study. Remdesivir is inhibits viral dependent RNA polymerase. And it was shown in studies prior to this to have activity against SARS-CoV-1 and MERS, and then in vitro activity against COVID-19, and consequently it was an early target for possible therapeutic intervention. So they performed a randomized double-blind placebo-controlled trial of over 1,000 patients, and it was actually stopped early because they reached their primary endpoint of shortening the median recovery time. And as you can see in the graph, it shortened time from 15 days in patients receiving placebo to 11 days in patients who were on drug. Go to the next slide. So this is a chart that depicts a lot of their data, which we don't need to focus on much of it, but you can hit the advance. It's going to pop up an arrow for us. This is where on the graph, that top arrow shows the 15 to 11 that we just discussed, the shortening of the median time to recovery. The bottom arrow is an outcome that a lot of us would have liked to have seen more about. So numerically, remdesivir decreased mortality from 11.9% to 7.1% in the treatment group. Unfortunately, this is not statistically significant. So there are certainly many of us who would like to have seen this trial go a little bit longer to see if we would have reached mortality benefit, but more to come, I'm sure. This slide, we've all heard about hydroxychloroquine in the lay press for sure. And I apologize, in the transmission, these graphs seem to get a little bit messed up. But in the first top graph, you'll see Tang and colleagues took 150 patients and open labelly assigned 75 to receive hydroxychloroquine, 75 to receive placebo. And then they tracked what percent had a negative conversion on their SARS-CoV-2 study at 28 days. And as you can see, there was no benefit in giving hydroxychloroquine in that study. This bottom study, Mehra, I can't say his name, and colleagues did an extensive review of the literature, enrolling 96,000 patients from the literature and grouping them by did they receive placebo as the blue bar, chloroquine alone as the gray bar, hydroxychloroquine in green, chloroquine and then hydroxychloroquine combined with a macrolide in the yellow and red bars respectively. And as you can see, in mortality, they did not see a benefit with any of these drug combinations. Now, I will add that this study is receiving a lot of attention right now. For one, it received attention because there was no adjustment, if you will, for the fact that patients who are sicker are more likely to get drug. And so placebo, were they really as sick as the treatment group, if you will. But more recently, just yesterday, questions started to be raised about some of the data in this study. And so there's more to come as to whether or not this study is even going to be something we talk about 2, 3, 4 weeks down the road. So suffice it to say, hydroxychloroquine Early results may not be promising, but we don't really have robust data, and there certainly are double-blind placebo-controlled trials ongoing as we speak. At Vanderbilt, the ORCID trial is ongoing to study this very question. We also are studying convalescent plasma in a double-blind placebo-controlled trial called PASSIT-ON. You may have noticed I mentioned proning in the ICU study or supportive care earlier. We're also studying proning on the floor. So there has been anecdotal data that some of these patients feel better or have reduced oxygen needs if they're prone. And so we're actually studying randomizing patients to either prone themselves or routine care and see if that has any effect. And last but certainly not least, remdesivir is continuing on in study in the ACT-2 trial, where remdesivir is being randomized double-blind study comparing, a randomized double-blind study comparing remdesivir to remdesivir baricitinib. So baricitinib is a Janase kinase inhibitor and an immunotherapy that is thought to possibly reduce that body's response, that immune response that we have in the second and more critical illness type phase. And we'll see if that has any effect on outcomes. Just a quick mention of some of the everyday medications that have been discussed in the lay press. So early on, people worried about NSAIDs. I will tell you there's no evidence connecting the use of NSAIDs to worsening of COVID-19. There was discussion about ACE inhibitors and ARBs, and do they treat COVID-19 since the virus attaches an ACE2 site. There's no data to suggest that it does treat or that it is harmful to continue patients who need these medications for other indications. Similarly, steroids, no unique effectiveness in the treatment of COVID-19, but certainly okay to continue patients who need this medication for another indication. And then some vitamins, particularly vitamin C, got a lot of discussion in the lay press early on, but there's no evidence to suggest there's a benefit from these vitamins. We can skip this slide. It referred to something else. So we are fortunate to have the COVID to Home program at Vanderbilt. It follows all COVID positive patients at VUMC through their course of illness. So whether they presented to the emergency department, tested positive, and were discharged, or whether they're admitted and on the floor or admitted in the ICU, they are all followed by the COVID to Home model when they leave the hospital. And this enrolls all patients who are positive for SARS-CoV-2. Go to the next slide. And the program involves three levels of care. So those patients who really were either asymptomatic or very mildly symptomatic when they presented may simply get phone calls for several days, but throughout the course of their illness. So until we're sure that they've recovered from the illness. Patients who were sicker, either requiring higher levels of oxygen supplementation or just had comorbidities that made them stay in the hospital longer, those sorts of things, they may receive telemedicine visits regularly throughout the course of their illness until we're sure they're clear of the virus. And then obviously those who are most sick, our intensive care unit players and so forth, they may receive the hospital to home arm of the COVID to home model. And this is nurses in a home care setting visiting patients regularly to, again, make sure that they stay well throughout their illness. This has allowed us to, discharge some patients that we might have held on to longer, but it also allows us to really feel comfortable that even if we let them go at day 4 or 5, somebody's looking at them at day 8, 9, and 10 and making sure that they continue to do well. And if not, that they have the appropriate interventions to help them get through the illness. Discharging to facilities has been a bit of a challenge. Skilled nursing facilities and inpatient rehab hospitals are requiring 2 negative tests in COVID-19 patients before they can transfer to their facilities. And even some assisted living facilities and nursing homes from which patients came are requiring this for them to return. And patients, you may or may not have heard this part, but patients can stay positive for weeks. And even though we don't think they're infectious past about 10 days, we just can't get the test negative. So there are patients who hang out with us for a couple weeks while we wait for those negative tests. So this slide just shows outcomes reported from New York. One of these studies Richardson and all is actually 5,700 patients in New York. The Cummings study was smaller, but their outcomes, they had about 15 to 20% of patients that were admitted to their hospital required ICU level care. 75 to 90% of those were mechanically ventilated. 66% of the critically ill required pressors and 31% dialysis. Few patients were treated with ECMO, and the overall data suggests 20 to 40% of critically ill die. 8% of all admissions died in these two studies. What are our outcomes at Vanderbilt? And this actually, I just updated it this morning. We've had 215 admissions rather than 209, 170 discharges. 62 patients have been critically ill and treated in the intensive care unit. 34 have been mechanically ventilated. Our mean duration of ventilation is about 2 weeks, which is actually a little bit notably, I guess I should say, less than the literature, which suggests 18 days. We've had 3 on ECMO, 13 requiring dialysis, and we've had 20 in-hospital deaths. With that, I will open it up for questions.
Thank you so much for all of that information. You filled a huge gap that we've not been able to fill since we tend to be kind of pediatrician heavy over here. So I really appreciate you sharing that information. So I had a couple of questions to start out with. When you're admitting patients to the ICU that don't require mechanical ventilation, is that because of mental status changes or because of need for blood pressure regulation, or what typically?
Great question. So our patients are co-localized in one unit at this point in time. So our MICU that was there before this began is there and still taking care of intensive care unit patients who are not COVID patients. And those who are COVID positive and requiring ICU are co-located in one large unit of the hospital with the floor patients. So patients who are on high flow nasal cannula but seem to be requiring a lot higher and higher levels of support, whether it's blood pressure or somnolence, but sometimes just the rapidity of the change from 6 liters to high flow nasal cannula. Those sorts of things make us just want to monitor the patient more closely than our floor patients. So we transfer them to the ICU to continue that high flow nasal cannula and just be at a lower nursing to patient ratio in case they do get worse. So sometimes it's literally just the quickness with which they seem to be deteriorating that makes us want to watch them a little bit more closely.
Okay, thanks. We had a little trouble with your audio there for a second, but just to reiterate what I think I heard you say was that sometimes it's just so they can be monitored a little more closely when they're on high flow oxygen versus maybe needing some little higher level of support with hemodynamics, but there could be a variety of reasons. Is that what I heard?
Yes. In some patients, it has more to do with the rapidity of a deterioration. They haven't gotten far enough where we say intubation is necessary, but they've just had a change that's happened rather quickly. And so we want a lower nursing to patient ratio for that patient just for some amount of time. And we can do that easily because they're located all in the same unit.
Gotcha. And then, so we talked a lot last week on our webinar about the new multi-system inflammatory syndrome that we're seeing in kids and how it's sort of similar to what you're seeing in adults, except adults tend to do it all in one fell swoop, and kids tend to have this asymptomatic infection followed by this period of maybe 2 or 3 or 4 weeks. And then they have that hyperinflammatory response. Have you seen younger adults in your unit, 18, 19, 20-year-olds? And does there seem to be some kind of transition where that window between having an asymptomatic infection and kind of crumping from the hyperinflammatory phase seems to shorten with age? Or Is that not something that you've really been able to make any predictions about?
So I would say most of our patients who are in the unit, first of all, are the older population. That's clear. We have had a few younger patients. Nobody as young as the teens, I don't believe, but we have had some 30-year-olds and maybe one 20-year-old in the unit. Remember, some of our experience too is skewed from the fact that the patient may have been accepted in transfer. So we certainly had a young patient who came to the unit and was rapidly put on ECMO, but they came from another facility, and I don't know that how long their presentation was before they were transferred, because I didn't take care of the patient myself. So we have had one patient who I can think of who appeared to have, who was young and had a more fulminant picture, but I can't say that that's a clear pattern that we're seeing yet.
Okay, thanks. So we have a few questions from the chat box. So the first one I'll address. So someone asked if the increased number in hospitalizations that we've seen in this last week could potentially be related to some increased clusters in the Hamilton County area that were associated with certain work sites. And so I don't have a county breakdown on hospitalizations at this point. I'm not sure if we have data on that available. It's certainly not data that we publish at this point, but it's an interesting thought to to think about. Well, is that large jump in hospitalizations that we've seen this week related to one cluster or not? There has been some interesting information that's come out in a study or two over the last week to suggest that people who are asymptomatic or very mildly symptomatic may pass on more asymptomatic or mildly symptomatic disease to others, perhaps related to the viral load that they have to share to other people at the time. So it's, I guess it's possible one could think that if there was a cluster of that started with someone who was more acutely ill or more significantly ill, then are the people around that person more susceptible to develop more significant disease that might lead to hospitalization? It's an interesting thing for us to take a look at. There's a question for you, Dr. Rice. Could much of the serious complications like acute kidney injury, coagulopathy, CNS, vasculitis, et cetera, be accounted for by SIRS or sepsis rather than any unique SARS-CoV-2 characteristics?
Another great question, and that is still being studied, I'll tell you. So we have, when you look at, let's look at kidney failure or at least kidney injury, and when you read the articles about why do we think this is occurring, it's everything from, in some patients, they clearly respond rapidly to fluid resuscitation. And so, they're dehydrated, not a surprise. These are febrile patients who may stay home for several days before they present to us. So they may have some increased insensible losses and become volume depleted and need fluid resuscitation at presentation. But there are other patients who don't have that. And there's certainly hypothesis, as I mentioned during the slides, we know that the virus attaches to ACE2, which is highly prevalent in the lungs, in the heart, and in the kidneys. I'm not sure about the brain tissue as much, but so there's certainly thoughts that this is really, and actually radiographic studies, and I'm not an expert on this, but where they literally can show that the virus is in the kidney cells itself. And so this may be a direct effect of the COVID-19 virus on the kidney cells, affecting and causing this kidney injury and even kidney failure. So it's, and yes, many people are thinking that it may be related to the inflammatory response itself or a thrombotic complication. So all of these are being enumerated as possibilities and being studied right now to try and determine which, if not multiple ones, are the cause of this organ failure in patients who are critically ill.
Great, thank you. And another one for you, for those patients with seizure disorders due to COVID-19, is there any information regarding resolution of that seizure disorder? Is anti-epileptic recommended for seizure recurrence for any specific period of time if you're discharging someone who's had seizures in the hospital?
So the incidence is very low. In that study of 240 patients in China, they only had, I think it was a 0.9% incidence of seizure. So when the incidence is that low, it's really hard to study and make clear recommendations. We haven't had that manifestation at Vanderbilt, so we haven't had the opportunity to ask our neurologic colleagues if we should. I suspect because of the unknown, they would say, at least for the time being, we should discharge with anti-epileptics. But again, that's a hypothesis on my part. We just haven't seen enough of that yet to determine what sort of treatment we should use in that situation. And unfortunately, that's the case for a lot of this stuff. You read through the literature and it's just many things don't have enough of an incidence yet for us to sort out all the fine details.
Thank you. And what are your suggestions around how providers should be following up patients that they see in their offices who don't require hospitalization once they've been diagnosed and they discharge them? Have there been any recommendations about frequency of checking those folks back?
So I don't know of any clear recommendations, but I will tell you my recommendation. We know that these patients, like I said, start to deteriorate if they're going to somewhere around the 1 week mark. So if you happen to have a patient who, were notified that they were in the emergency department and they tested positive, in some format, you want to start touching base with that patient around the 6, 7, 8 day mark to make sure that they're still doing okay, whether that be via a phone call or telemedicine. We don't seem to have any requirement that it is done in person because you can check in with them in these other methods. But I would recommend checking in less than, typically standard, I think the standard discharge follow-up visit has to be, quote, within 2 weeks or something like that. But really in these patients, I would recommend much sooner, more at the 1 week mark. And that's what our COVID to home model really helps us with, is they follow these patients regularly through that 8 to 10 days and usually about 2 weeks out before somebody, graduates from that program.
Great. So can you shed a little light on the kind of the policies at Vanderbilt around PPE specifically? When are your different types of providers, whether they're nurses or physicians or therapists or radiology techs, when are they wearing cloth masks versus surgical versus N95s, and what about gowning in when working with hospitalized patients at Vanderbilt who are COVID positive?
So we have multiple facets, I guess, to our infection control processes. Everybody on campus now is required to wear a cloth mask when we're on campus. So as soon as we arrive at work, we're all donning some sort of mask. I shouldn't say cloth mask. It can be those throwaway masks as well. But we're donning a mask as soon as we get onto campus. All of our patients are localized, as I mentioned, in one unit. Our positive patients are localized in one unit. So if you're not on that unit, you don't have to don and doff and all those sorts of things to see patients. But when you're on that unit, you're literally doing that with each and every patient. We've minimized the number of providers who are on those units for a couple of different reasons. One, just the sheer logic of we can't have everybody sick at once, so we don't want every person, every 2 or 3 days have a new face showing up to see these patients. But it also has to do with the expertise of donning and doffing. Doffing or taking off, I'm not a fan of that word, doffing, I have to admit. Taking off this equipment is a high risk time. And so being an expert at that is important. And we minimize the number of people who are interacting with these patients and having to be an expert at that process by localizing these patients onto just a few teams. So we have 2 different hospital teams right now that are actively seeing those floor patients. And then the MICU has a nurse practitioner team, and it is that team that is actively caring for all of the ICU level patients. When those providers see a patient, they are, within an N95 respirator, they are gowned, masked, gloved, and the whole thing. A lot of the ICU providers are trained in PAPRs, and so they're using that more probably than the N95s. Then the rest of us, so the questionable patients, the persons under investigation, are admitted to a different location called, my unit, the TOBS unit. And in those patients, we don't use an N95, we use a surgical mask instead. But we do still gown and glove and that sort of stuff with seeing those who are in question. Is that, I don't know if there are other pieces to it that you'd like to know about. Those are the ones I can think of off the top of my head.
The one specific thing that they put in here was that there were, it says, I see Vanderbilt staff like ultrasound techs that are in close contact with patients wearing cloth masks. What does the data say about cloth versus surgical mask?
So I will tell you that they're doing that. They're either not entering a COVID positive room or they are not doing what they're supposed to do. So anybody who's entering a COVID positive room has to be, completely with mask, gloves, and face shield. So, I'm not sure which techs were doing that, and I'm not sure where that was. But in that COVID unit, they are donning and doffing no matter what line of care you are in. Now, I will say we've done a lot of things to try not to have as many people enter the room. So I don't have the picture, I wish I did, but my husband took a picture of the ICU beds where they've literally moved the controls for the ventilator out into the hallway. They have moved IV lines, they've lengthened the line and moved the IVs, the actual pumps and things out into the hallway. They've even dialysis machines can be stretched to run outside, some of it outside in the hallway. So that way people are not having to enter the room as often and use PPE to try and conserve it. So we have done some interesting modifications to try not to enter the room, but if we're entering the room, you should be donning and doffing completely.
Okay. There's a question that asks, younger people have been noted to present with significant cerebrovascular events. Is it wise then to have them prophylaxed with a low-dose aspirin? And if so, at what age?
I missed the first part of that question. Did I hear?
For younger people who may be at risk for presenting with cerebrovascular events, is there a recommendation to prophylax any of the populations with low-dose aspirin?
There are no recommendations at this time to prophylax, whether it be just the general population or even those who are known to be positive but are like discharged at home or something. There's no recommendation for prophylaxis in that setting. If somebody is admitted to the hospital, as I mentioned, we certainly give prophylaxis to those patients. And upon discharge, whether or not they receive any therapies would really depend on the discussion about their risk and the risk of personal risk. Thrombotic questions. Right now, the American Society of Hematology and the National Institute of Health really trying to encourage us to get people in studies so that we can answer any of these questions. There's no recommendation to prophylax with aspirin or another agent at this time.
Okay. And so I think when we talked to Dr. Schaffner, I guess 3 or 4 weeks ago now, I believe he said at the time Vanderbilt was not testing all of the people that are coming in for elective or any surgical procedure that required intubation. Has that changed at all, or is Vanderbilt still not doing that across the board?
Yes, Vanderbilt is screening all admissions to the hospital. So we have 2 different testing platforms to try and accomplish all this testing in a timely manner. But yes, everybody is being tested. If we are doing a surgery that is elective, then they're tested within a day or 2 prior to presentation. But anybody who gets admitted through the emergency department or from a clinic visit or something like that, everybody's tested before they enter the hospital.
Great. And do you know what advice there is about using PPE in this question is specifically about an ED, but we have the same question, especially in pediatrics, when we see a lot of respiratory conditions that, you know, the chance of the child in front of you having COVID-19 is pretty low unless the family is sick in most cases. But is there advice around people who are just seeing people who are generally ill and what degree of PPE they should be wearing in those cases?
So our emergency department now is set up where before you even enter the emergency department, you're screened with your temperature taken and questions about have you had any symptoms that could raise concern for COVID-19. If somebody screens positive that there is concern, they're moved to a different area of the emergency department. And in that area of the emergency department, all people there are using full gear. We're definitely trying to balance that phenomenon of burning through PPE against protecting workers. But we also are, you're aware that this is influenza. This is twice as infective reportedly as influenza. So we need to be cognizant of those that do raise concern. And our persons of investigation will use the appropriate PPE for those patients. That's not, we do have many people getting admitted who are being tested just as an asymptomatic patient being admitted for something else, and those we do not use PPE for. So I don't know if that directly answers your question, but I would say we err on the side of caution, I suppose.
Yeah, sure. Yeah, it's it's definitely been an ongoing challenge out in the in the practices who still may not have ready access to N95s. They may only have one that has to last them a week, and gowns even across the state are an issue right now, and being able to procure those. So there's still a lot of challenges around getting access to PPE. We probably have time for one more question, and there's one asking for updates on the sensitivity of the Abbott ID Now test. So I had some time to Google while we've been here. And so Abbott just released some information on May 21st about some different comparison studies that have gone on, comparing the Abbott ID Now to a lab-based molecular PCR test, and it's sort of all over the map. There was one clinic study that showed 91.3% sensitivity, but then an ongoing study of hospitalized and nursing home patients with an 83.3% sensitivity. So Abbott ID Now still seems to be having some inconsistencies with the kind of sensitivity that we're seeing with that platform. And then there's a question about early data regarding the nursing home and assisted living testing that we've been doing across the state. And I do not have those numbers right now, but I will make a promise to have something to be able to share with you when we're back next week. So,
can I just point out one quick thing?
Sure thing.
You mentioned burning through PPE, and I will tell you that we are avidly trying not to do that at Vanderbilt using a couple different methods. So I mentioned our Huddle. That is one invention invention that we've created to try to reduce the number of people who actually went into the room and had to use PPE to see a patient. But the other thing we're doing a lot of these days is telemedicine, even in the hospital, to try and reduce folks having to enter rooms. So if people aren't using telemedicine, I encourage you that now is the time to embrace it, to reduce your need to use PPE when it is in short supply at times. Really has helped us a lot at Vanderbilt using telemedicine in a variety of settings.
Yeah, that's a great point, and you know, something that we've talked about on and off over the last few weeks. Even in an office setting, you can room patients and then talk to them on the phone from outside the room to get their history and get an understanding of what's going on, and hopefully reduce the number of people who need to go into the room and have contact with them and burn through PPE. So that's a really good point. Well, I just want to thank you for taking the time to share all of this really important information with the folks who tune in every week. And thanks for giving us all the insight from Vanderbilt. And maybe we'll talk to you about coming back on again in a month or two and see what kind of new stuff you have going on. Everything changes so quickly. It's great to have updates.
Yes, it does. Thank you for having me. I enjoyed it.
Yeah, and so everybody, next week at noon, we'll plan to be here again, and we'll talk a little bit about nursing home testing and data and some of the other vulnerable populations work that we've been doing over the last several weeks. So look for that registration link, or get to it at tn.gov/health. Go down to the go down to the stethoscope box and click on that, and there you'll find the link when it gets set up for next week. So everybody stay healthy, have a wonderful weekend. It looks gorgeous outside, and we'll talk again next week.